Afternoon, good evening, or good morning, depending on where you are calling in from. Thank you, Dr. Pezos, for joining us today.
Thank you. It's my pleasure, Kevin.
So our guest is Dr. Pezos, as I just mentioned, who is in Barcelona now at University of Barcelona. Did your residency there. Your fellowship was done in Oregon, but your medical school and your PhD is also from Barcelona. Is that correct?
Yeah, that's
all right.
right.
Make sure I had all that in there. So we're excited to hear what's going on, but first let's give us maybe a little bit of what's happening right now in Barcelona regarding your clinic and COVID-19 and how all that's impacting you.
Well, we are slowly starting some de-escalation. We've been starting to see patients that are not emergency cases only for a couple of weeks, but in a very slow manner. We are trying to keep strong safety measures. But little by little, our situation here in Spain. That we had a big number of at some point of people with COVID and problems, but now our numbers are starting to get better to allow us to do so. But still, I think we are acting with caution.
Have you opened up to elective cases yet in the Barcelona area?
We are doing some glaucoma cases now. We are not doing cataract yet. We are doing those patients that now they're in risk of blindness. We are starting to do also intravitreal injections, but very selective cases that really are at huge risk.
Sure. And how about the patients? Are they timid to come in? Are they apprehensive? What is the feeling from the patient side?
Yeah, we started at the very beginning of the pandemic, we started calling our patients, and it was interesting because at the very beginning, they actually didn't want their appointment to be canceled. They wanted to come, and we were saying, no way, you don't have to come, especially because our patients are old, so are in a high risk. But now, sometimes it happens the opposite. So now they are starting to be somehow afraid after all what they've heard, and because here in Spain, it really strikes us strong. Sometimes we have to talk to them, and it's a decision that we do together, that we take together, because sometimes they are afraid to come. We of course explain to them all the safety measures, but now we see the opposite thing.
And with telemedicine, is that something that's working at all in the Barcelona environment? Are you seeing any patients over digital media?
Well, we started calling all our patients. We did that at the very beginning, just so we could, talk to them and, try to assure that they were fine in the way we could. And now we are starting to do with these de-escalations, some telemedicine in terms of trying to make the patient come as less as possible in the hospital. So we are having some ideas that we are beginning to do in terms of, doing OCT, visual fields, IOP, and then maybe check the results at home and give them back a call, just so they stay the minimum time at the hospital. But,
right.
All these things are difficult because, glaucoma needs, as we will see today, so many different testings that we have to think about it.
Well, we're going to put up a quick poll question here that we're going to ask. So what GPA do you use to track your patient's progression? Either you don't use GPA function, structure, or a combination of structure and function as we go forward here. We'll see how this changes based upon what you have. And you're kind of anchoring a week-long of glaucoma talks that we've done on one on HFA, one on OCT, and now we've got really kind of tying it all together with the devices here with your talk. So I'm really looking forward to it. I'm going to go ahead and put my camera on mute here in a second, but for the audience out there, if you have any questions, please put them in the question and answer sections. We will be back to answer those questions with you here. So go ahead and mute your itself. Go sit back, enjoy this presentation, and I think it's going to be a great day. Thank you.
Okay, so in the next minutes, I'm going to talk about innovations in clinical management of glaucoma. And for the purpose of the presentation, I think it would be very nice to know what is innovation. So basically, innovation is the action or process to do something in a new way or have new ideas about how something can be done. But I like this second definition better, which is actually turning an idea into a solution that adds value. And if we are talking about clinical innovation, that necessarily needs to have a clinically application or a clinical application. Okay, so this will be the outline of my presentation. I will talk about structure, about new things in function, about how structure and function relate, about how can we assess progression, and finally a couple of slides about new technologies, especially OCT and geography. So let's go for structure. So now with OCT, we can do a global evaluation of glaucoma, a complete evaluation, and that's very important. We know that glaucoma happens at the optic nerve head, especially at the neuroretinal rim, in which we can see mainly the retinal ganglion cells axons. That's how we can actually see it in a high definition OCT. Then the axons of these cells go to the retinal nerve fiber layer. The soma of these axons are what we talk, or what we say the ganglion cell layer. And finally, the dendrites make one layer that's called the internal plexiform layer, or IPL. So OCT can assess each of these separate entities in a way that we can have a complete evaluation of the neuropathy. So we can see the rim, and we have the analysis of the area of the rim, disc, volume. Then we can assess the peripapillary retinal nerve fiber layer of these axons at the surroundings of the disc. And then at the end, we can see also the ganglion cell and EPL layer all together to have an idea of what happens in this location as well. These parameters have some strengths and some limitations, each of them. So for the rim, we will have first an idea of how the optic disc looks like, and we know that cupping is a very strong characteristic for glaucoma. Actually, this is what we will look most of the times clinically. It will be very helpful for us to detect asymmetry, and sometimes it has been said in some studies that it could be also a better parameter in discs that are not completely into normal limits and that are tilted. The other very important parameter, and is the one more widespreadly used, is the peripapillary retinal nerve fiber layer. It will be able to change even 4 years before the actual damage appears in the visual field. It's a very good parameter. It's not been overcome by any other parameter yet, and it has a very good discriminative ability. It's very useful in early stages, in mild to moderate glaucoma, and the better parameters that we have is the average thickness parameter and the inferior region thickness. And the last but not least would be the ganglion cell layer that, remember, in the CERES, we measure it together with the IPL. This parameter has been shown to be very sensitive, especially in suspects or in ocular hypertensives. The parameter that changed first is the GC IPL minimum. It's very good detecting focal damage or paracentral defects that are very characteristic of normal tension glaucoma. But because it's the end of the neuropathy is where the soma is, we also always need to look for a certain sense with the optic disc appearance. And the shape that it characteristically has, it has been called as a snail shell appearance, like you can see here in the screen. And it's also been useful as a complementary information when we see a tilted disc. And now the innovation in the latest studies is that what we have to do is not use one of these parameters alone, but combine them. That will lead to better outcomes, and current evidence suggests that using all together will enhance the sensitivity to diagnose glaucoma. So that's what we have to do. And I have some examples for you in which you will see that all the parameters need to be assessed as a whole. So here we have a 70-year-old male that we've been following for some years with ocular hypertension. He has an African descent that we know that this is a risk factor for glaucoma. And currently his IUP is 22, and we are thinking, well, should we treat? Should we still look just for changes? Whatever. We see these tests, and actually in the field, we see some inferior defects that almost here in the pattern deviation could be almost like a incomplete arcuate defect, but very mild. But it all makes sense. If you take a look at the disc, here we can see an inferior borderline situation, which will match with this superior zone that is also here and here. And also there are some mild changes in the ganglion cell layer as well. So if you have these three things and the pressure is not perfect, and then we also have the risk factor of being an African descent, I would probably treat this patient. And that's why we need to take all this together, because only with the field, maybe we won't be sure. Only with the optic disc, we possibly won't be sure. But when we see all together with the macula as well, then we will decide to treat. This is another patient. She's a 69-year-old female. She has an untreated IUP of 14, which is statistically into normal limits. And we're thinking, this is glaucoma or not? We see this field that has some changes here inferiorly, but they are very paracentral. We won't be very sure. And you know, the optic disc that looks not too cupped, maybe here a little notch. The peripapillary retinal nerve fiber layer is completely normal. Maybe if we see the hour clock sectors, maybe there's a borderline change, which we know it has high variability. So we typically not always listen to this. But when we take a look to the macula, we see this sign. This is also called the Raffi sign because it respects the Raffi area. And if we take a closer look to the macula, we see this snail shell appearance that I was talking about. And you know, this change is basically superior, and those paracentral defects are inferior. So yes, this is glaucoma, and it's probably a normal tension glaucoma. And I have one more example. So this is a patient referred to us because they think it could be a glaucoma suspect. He has 22 millimeters of mercury of IOP, and we see this structure. So the nerve, again, the head of the nerve doesn't look bad. We see all between normal limits and symmetric, not apparently not notches, rim looks good. Then the disc, the peripapillary retinal nerve fiber layer, again, it's between normal limits, both eyes. But when we look at the macula, the ganglion cell layer, what we see is something that's not very typical of glaucoma, which is a vertical respect. That is not glaucoma. Glaucoma doesn't go vertical, it goes horizontal. And if we do the fields, what we see is that the field actually looks exactly like the damage that we are seeing at the macula. So that's what I was saying, that it has to make sense with the optic disappearance. So if you have a very bad ganglion cell layer, very affected, you should have a very cupped disc, or at least some cupping. Otherwise, it's not glaucoma, or at least you have to look for something else just in case it's not glaucoma. And in this particular case, this patient had a cerebrovascular accident, a stroke. Okay, so next we'll go to function. And the new things in function go with the idea that sometimes 24-2 standard automated perimetry is not able to completely represent all the certain patterns of damage that glaucoma has. So we know that for each 3 decibels of visual field loss, a pretty important amount of retinal ganglion cells are lost. In case that this damage is peripheral, about 30 to 40% of cells are lost. In case this is central, more than 50, up to 70% retinal ganglion cells are lost. And we know that these 4 points here, by a lot of words, especially by this work of, Donald Hood, we know that macula is underrepresented with the 24-2. So in these cases in which we are suspecting a paracentral defect, we should do 10-2 better. So more and more studies are telling us to include somehow, or not in all, but at least in some of them, 10-2 as well. And I'm going to show you an example about this. So this is a 50-year-old female. She has a cup disc. Her pressure is 16. In the nerve, you can see here an important inferior temporal notch, very characteristic of glaucoma. This is a normal pressure. This is untreated pressure. And these are the tests we were talking about. Here we can see how the disc matches to the appearance. The peripapillary nerve matches to the appearance of the disc. It's this inferior defect. Also, we can see here in the macula that we have also this inferior defect that matches possibly with these little points, but these could be in a specific, we're not sure. If we do a 10-2 in these cases, we can see how this central defect is actually not that small. And these are the 10 degrees central, and it has a very close to fixation damage. So 10-2 is important to characterize pericentral defects. In this line, we will now have a new strategy that's called the CETA-FASTER 24-2C that tries to integrate 24-2 and 10-2 together. So on top of the 24-2, 54 points, it combines with 10 selected 10-2 points, those who have shown to be more specific detecting damage, and they do it all together in the same test. I have not examples for you about this yet, but we just got the software, and I'm excited to start doing this because it will probably save time to my patients. So next innovation would be, what are the new trends in structure and function relationship? So we know that structure and function do not always go together. Sometimes they do, sometimes they don't. But we still know, and there are some patterns that we can have as a help or as a tip. So what we know is that in early glaucoma, like in here, in which the thickness is still very good at the beginning of the neuropathy, the structure changed earlier, and it's very good detecting damage. You can see in green the structure, in blue the function. So structure changed first. That means that OCT has more value in early stages of glaucoma. If we go at the end of the neuropathy, right to the other side, and this is a very nice work of Felipe Medeiros that I always use in my presentations because it's very helpful to understand that in these cases, then it happens the opposite, because the OCT has a floor effect and it arrives at a certain point in which it cannot lose more. Then in those cases, possibly visual field gives us more information. And then there's a middle situation, like in mild to moderate glaucoma, that structure and function go together a little better. They are more correlated. So in these cases, possibly structure and function go easily together, and it's easier to understand. But that's why we sometimes find things that don't match. The other important new thing that I think we should use in our patients, or it has been helping me a lot, is how to assess progression. Because, glaucoma is a progressive disease, and that's what it's very characteristic of the condition, and what it makes it different about this condition and other things. And it's important to evaluate both structure and function over time. And in my opinion, trend analysis is the more important. The other could give us information, but evaluating linearly trends is more intuitive and more simple. And actually, it's able to detect most of the eyes that basically would later have a clinically significant progression. And I'll go through this a little bit later, because clinical significant progression is a very important concept. And it has also been shown that trend analysis is the most important parameter to actually start treatment or change treatment. But have in mind that it's important to have enough tests to have a good rate of progression. At least 5 tests in 2 years is what it's more recommended. We'll do first function over time. As I said, trend analysis is the one I think is more important, but we also have event analysis that will help us with focal change. And now with the current softwares, we can do trends with visual field index and also with the mean deviation of the Humphrey visual field. Remember that in this analysis, age is always incorporated. So our idea, if we want to have zero progression, is to have a flat curve, no slope. If we have slope, that means that this patient is progressing at a greater extent than what it would be supposed for him for a certain age. And again, this concept of rate of progression that we can have also with these progression analysis that are really helpful. But the big question is, what rates then of progression are clinically relevant? So what we know is that there's a certain amount of progression that's really too much. It's what we call fast progressors. And we should not let our patient progress more rapidly than these values that you can see over here. So in terms of mean deviation, minus 1.5 to minus 2 decibels per year, more than this or this is way too much. And in terms of FFI, or VFI, sorry, then this change is from minus 5 to minus 10% every year. This is clear. But there are other situations in which it's not that easy. And what the concept that's now more implemented is that we have to treat a patient or to do things in our patient, surgery, changes of treatment, being more aggressive, in cases of clinically significant rate of progression. And that means that an amount of loss that could lead to our patient to have an important future visual impairment or blindness in the future. Which factors do we need to take into account? Age, in terms of life expectancy, how the severity of the disease. I mean, in a very advanced glaucoma, it's, maybe it's not too fast, but there are very few ganglion cells left, and maybe just a little bit more of loss in the visual field will be way too much. Presence of known risk factors. We know that there are certain glaucomas, like pseudo-exfoliative glaucoma maybe, that progress really fast, or as we said in a previous example, like African descent, also progress fast. And also depending on the quality of life, on the everyday activities of our patient. All of this has to be taken into account. And maybe there are some patients that are progressing who, glaucoma is a progressive disease, so our idea is to, live with progression. Maybe it progresses a little bit. It's okay if it's not too much to impair their life. That's the idea that we have currently. And I have one example here. For example, this patient, she's a 79-year-old female. She's now in 3 drugs. And we're thinking, should we operate her or not? We see that there's a trend. It's not like a super big slope. It looks like not too big. But when we take a look at actually to the rate of progression, it's minus 3.4% a year, which, as we said here, it's not that much, right? So maybe in this patient, we could wait, but we will need to talk to her. Also, remember these changes in the central field, that also this capacity to split fixation also needs to take into account. But my recommendation is to take a look to these numbers, because sometimes we just look, this is a slope and it's significant and that's it. And we need to understand what these numbers mean. And the other thing that we need to change in our minds is that Humphrey Visual Field Assessment is not static anymore. It should be dynamic. And now with the new softwares, we can interact with data. That means we can exclude those tests that are not reliable enough. As I said before, VFI and MD are now available, but they are also available as a trend analysis. So it's important for us because sometimes the percentages, VFI sometimes is more difficult to see as a progression, and decibels sometimes sound better, but you can choose, so it's good. And then we can also now put the clinical events that for us are important, for example, a change of treatment, a surgery, something that happened that we want to have in the same graph. And also we can now have dual baselines, which is good because prior to this, you could go inside the Humphrey, you could go to the machine and exclude those tests, for example, that were done before your intervention. But then you were losing some information. And I have an example for this. This is a patient with a pseudo-exfoliative glaucoma. He was not very compliant and he came for some time and then he didn't come anymore, and then he came again, and we were seeing a really fast progression. At this point, we did surgery, and then we can see how the curve starts to flatten, right? But we could improve these outcomes. How can we do this in terms of, for us, for understanding? Because now we have here a -2 decibels per year loss, approximately. But this is not true. Possibly was true here, but maybe here is not anymore. So this somehow interferes in the whole mean of the evaluation. So what we can do now is to first put here that we did surgery, exactly in what time of this graph, at what moment of this longitudinal data we performed the surgery, and we also can change to have a dual baseline. So we have these two first tests as the first baseline, which is this -2 decibels that I was talking about. And after surgery, we can set then another baseline and have a second trend, which is now a lot less, -0.1 decibels per year. That is very helpful because we can see very graphically how our surgery was able to flatten progression. And again, not only function is important, it's also important to assess structure over time. And we need to understand or have some ideas of how to assess OCT changes over time. The most used parameter, again, would be retinal nerve fiber layer. It has very high sensitivity and is very good for this. It's very useful, again, in early glaucomas, but not so much in advanced glaucomas. And that's because of the floor effect that I was talking about. It approximately happens around 50 to 60 microns. That after that, below that, it doesn't have more range, doesn't go lower than that. You can be progressing and it will be forever like this. The significant amount of change in terms of peripapillar retinal nerve fiber layer would be 5 microns. Less than this is possibly variability of the measurements. These numbers change depending on the region, but I typically try to understand that 5 microns is the number that I like to have in mind. So the change related to aging, it would be, again, this 0.5 microns. So my way of remembering is that age would explain 5 microns in 10 years. And the significant amount of change is, again, 5 microns. That's how I remember. But we have to be very careful with slopes in terms of structure. And this is different from the GPA of the visual field that we are all used to. In the case of OCT, the slopes are not corrected by age. So if we only take into account that the slope is significant, we will have a high rate of false positives. Actually, this study is very good showing this. And if we use just the idea of slope and we wait enough time, just because of aging, almost 100% of our patients would progress. So what we now consider is the lower limit of these changes. And what we consider clinically significant would be a rate of structural progression faster than -1 micron per year. For example, showing these ideas of progression, this is a 53-year-old female. We have done multiple changes of drops, adding drops. Now she's still not well controlled. She's 22. Should we do surgery? Well, if we look at the fields are not too bad, because it's a very early glaucoma, almost no damage in the field, in a specific points here that they disappear later on. Maybe here we start to see some focal changes, but this is very stable, or it looks not too bad, right? But when we look at the structure, because this is an early glaucoma, so the structure will help us more, we see that it's actually losing a lot. It's like -3 microns every year. We said that more than 1 is way too much. And again, even focally, this is very, very graphically, you can see it easily, it's losing superior and inferiorly. So definitely we need to do something with our patient. The other structure that we can also see over time, and this is sometimes dismissed because the retinal nerve fiber layer is used so much that we sometimes do not use the ganglion cell layer in progression that much, and that's an idea that it's currently changing, is that although it has overall less sensitivity, that retinal nerve fiber layer, to detect progression, it's a lot better than retinal nerve fiber layer to evaluate progression in those cases in which that floor effect that I was talking about has happened. So in advanced glaucoma, it still has the possibility to detect some structural change, and that helps. The same parameters that I was talking about in the previous slide, for the ganglion cell layer, the significant amount of change exceeding variability would be less -4, a change of 4 microns. And the same numbers related to aging would be around -0.32 microns per year. That would be aging. That's not pathological. And how does that help us? This is a 75-year-old male. He already has had surgery. Pressures were good at the beginning. Now they're starting to climb, but the fields are not too bad. It looks like, he has a very advanced glaucoma, almost no superior field, but they look stable. They don't look like progressing too much. And if we take a look to the optic nerve, retinal nerve fiber layer, we see again that it's flat, no changes because it's in the floor effect. This is an advanced glaucoma, What happens to the ganglion cell layer? Well, it started pretty well, but now it's starting to change. And actually in the workplace, we can see very nicely all these together. So here we have the fields. Here we have the retinal nerve fiber layer that it's not changing because it's in the floor effect. And if we go we scroll down, then we see the ganglion cell layer. And we see this trend, but we see also how, despite the fields do not look like progressing, and because the floor effect of the structure, we could be missing that actually the patient is progressing in the center, in the macula with the ganglion cell layer. So it's good in advanced patients to also look at structure. Despite the fields sometimes give us a lot of information, sometimes the structure still changes earlier. So it's good, again, to assess everything together. And the final point is just some slides about new technologies like the OCT angiography. And, this is like the chicken and the egg with the vascular dysfunction and glaucoma. We don't know what happens first, but there are some studies showing interesting results, like, for example, saying that possibly OCT angiography could have a better structure and function relationship because the OCT angiography, in terms of vessel density, has a less floor effect than the structure. So RNFL has a floor effect. OCTA has a less floor effect. So possibly that's why the correlation is better in OCTA with higher R2 values. There are also interesting results in early glaucoma. There are small studies, so we need further evidence to say this. But interestingly, in some studies with preperimetrical glaucoma and controls, they found that the density of the vessels around the papilla had a highest sensitivity and specificity detecting early glaucoma when compared to retinal nerve fiber layer around the papilla. That's very interesting. This was also found in a different study with 33 eyes in the contralateral eyes of the other eye being glaucomatous and controls, and they found again that the OCTA around the disc and in the disc could detect with better outcomes changes in structure compared or early glaucoma compared to structure. That could be a sign of sick cells, but maybe it could be that before thinning, they change things in flow or in density of vessels. But we don't know because this technology has still some limitations. Artifacts, movements, shadowing, projections of the big vessels that the new segmentations will need to address. Also in terms of other diseases, like for example, AMD, it's not able to detect leakage as well as angiography, maybe. Also, we will see with new technologies that go deep in the nerve, but with the current technology, we cannot see very well retrobulbar vessels, so we don't know if only the superficial vessels are involved or maybe the more profound vessels are involved as well. Necessarily, the patient needs to be sitting down. Other previous technologies like echo Doppler could be done in a supine position. It actually needs a very good collaboration of the patients. If it moves a little bit, then you see this motion artifact and all the parameters change. And we don't have still a normative database to actually have a good comparator and see if this patient in this area has a significant change or not. But still, I have some examples because this is for me promising and it has limitations, but we need to study more. I have this 76-year-old patient. He has an advanced exfoliative glaucoma in the right eye. And we know that for sure because all matches, right? The nerve, the macula, the fibers, and the field, all matches here, easy. But how about the other eye? Let's see the other eye. Is he starting something in the other eye? Well, we see some points here, but this is very inspecific. Again, let's go to our 1, 2, 3 idea. The nerve looks not too bad. Actually, we have the parameters here and they are all okay. The retinal nerve fiber layer, again, is between normal limits. Maybe it's just that he's not doing the field well, although it's reliable. But, maybe it's just a first field, something like this. We did a OCT angiography. Look how different the eyes look. This is the very advanced eye. I have put here the field for you so you can see. And actually, there's no microvasculature. It's all gone. It's all black, right? And here in the other eye, it's interesting to see that we see very well all this vasculature here, inferiorly and all in these areas. But here superiorly, there's possibly an area that could match those inferior points that we were seeing. And this was only a hypothesis. But we then repeat later on the test. And what had happened is that actually that superior area that we were seeing in the OCTA, actually now the patient had a thinning of that area in structure. So who knows, maybe it's true that we can see vessels. This is only one case. This is just for discussion to have it in mind. But again, there are not conclusive studies about this. So just as a summary and conclusion, the take-home messages that I would like you to have is that it's important to combine all parameters in terms of structure to evaluate the neuropathy as a whole, rim, peripapillary nerve, retinal nerve layer, and the ganglion cells. Remember that 24-2 could underestimate the central points, and that more and more we are using complementary 10-2. That structure and function relationship depends on glaucoma severity. In early glaucoma, OCT works better. In advanced glaucoma, visual field works better. That it's important to assess a clinically significant rate of progression, that it's known in fields that a fast progressor would be when it exceeds minus 1.5 to minus 2 decibels per year, or a change in VFI greater than minus 5 to minus 10%. Although there are other risk factors, and conditions of the patient, age and life expectancy that we also need to take into account. In OCT, those changes would be clinically significant if they are greater than minus 1 micron every year. And that there are new technologies like OCTA that are promising, but that they still have important limitations. And well, that's all. It's been a pleasure for me to be here today with you. Please do not hesitate to make questions. And I only, because of the difficult times we're living, I just wanted to, in any phase you are, in whatever phase or wave your country is, I'm just wishing you strength and the best for all of you, and please take care.
Well, Dr. Pezos, that was an excellent presentation. Thank you so much for it. And for the audience out there, if you could go ahead and take a look at this poll and take it again, we're gonna kind of compare the answers and how they came. So it's fascinating work that you have going on. And I know it was just one case that you showed with the OCTA, But have you seen that starting to evolve over the years, getting more and more usage and acceptance?
I think it is promising, and I can see that there will be changes in segmentation in the future. We are actually conducting a couple of studies with it, and I'm sure things will make that this technology goes further.
Yeah, I'm sure there's no shortage of companies that are working on solving some of the things that you
Yeah.
had out there. And again, for the audience, please put your questions in the question and answer. I'm going to ask you a few that came in, if it's okay. So
Of
one of the
course,
things
yeah.
is, this is, I think, the one question we get asked all the time, and that's about the 24-2C. How much longer does it take?
Well, it actually takes less than the regular 24-2. So there's a couple of studies that I've seen. As I said, we just got it. I have not used it, but it's supposed to take about 20% less time than a regular 24-2. Of course, it depends on the patient. Some patients will need more, some patients will need less, but it takes less time than the conventional 24-2. So I'm looking forward to showing you other examples with it, but it should be faster.
And then another one is, in what cases do you decide to acquire OCTA images?
Well, that's a very good question because, of course, we don't have so much time to do all tests that we want sometimes. But I really like to do them in normal tension glaucoma. I almost do this in all my patients because of the vascular factor that we know it plays a role in this glaucoma. And as I said, we are also performing a study. So there are some patients that I'm doing them by routine, but it's just because I'm doing some research about it. But I'm now strongly doing it in normal tension glaucoma.
So somebody is giving us live updates here. They said, I did a 24-2C on myself today, and it was just over 2 minutes an eye.
Yeah,
so that is
that
one
should
of
be
our
it.
live attendees. So thank you for that information.
Yeah, thank you.
So in terms of progression, OCTA mentions that loss of 1 micron or more a year is significant. Is this the same in RNFL and GCL?
Well, so this is my recommendation after some studies that have been done mostly with retinal nerve fiber thickness. So there are not such of a studies that I know of done in GCL, but I don't think it would be very much different. So clinically significant in terms of a structure about fibers, it should be less than 1 micron per year. But remember that you need to have enough tests.
Sure.
So you need these 2 years and these at least 5 tests to make these numbers.
And so here's one that maybe we can answer in 2 parts here. One is, can a 24-2C be done with ZEISS standard?
I don't think it can be done with ZEISS standard because it's a separate software that it's done with ZEISS faster, but it can use your previous 24-2 ZEISS standard in the GPA analysis, which is good. Because sometimes when you have a new software thing or a new change, if you cannot use your previous test in a disease that in which progression is so important, then you feel bad, right? But again, in a 24-2C, you have the 54 points of a regular 24-2. Of course, it's not going to be exactly the same as a standard, but it should be similar.
Do you think that you'll mix strategies going back and forth now that you can use the glaucoma progression analysis with the mixed thresholding? Do you think you'll mix them through, or what will be your go-to tests?
I think that's a very good question, and there are still some, there are some studies that I know, but of course we need to see the faster in general strategy, how it goes through time, because we've seen that sometimes making tests shorter is very good because patients do test better, but you have to arrive into a certain balance, because if it's too fast, then you lose certain information. So my idea now is to see how can I do this, but it will make sense. Once you have a very good tendency, a good trend with your standard, maybe it will be the time to switch to faster, because then you have enough information to do that. But we need, prospective studies done with this to make sure this makes sense.
Yeah. So a question, what would you be advising? This is, I'm not sure where you're practicing medicine at this point, what country this question comes from, but please give your advice. If an IOP of 25 and a young person with no other risk factors of glaucoma be monitored in your practice? What would be your treatment on that? It seems like we don't have enough information, maybe.
Yeah, I think we don't have enough information, but only a pressure cannot be, exactly. We don't have enough information, but 25, at least it needs to be seen at least once with some testing, because maybe he doesn't have other risk factors, but maybe you see something strange that or maybe he has we don't know the pachymetry, we don't know other things, but just because your pressure is 25, you definitely don't need to see the patient every 6 months, right? It just depends. But again, all this idea of combining things will give you a better, sense of risk in this patient. If everything turns normal, maybe you don't need to see him anymore.
And so let's pivot that in this other question. In early glaucoma, how often would you recommend doing OCT or OCTA in patients that have early glaucoma?
Okay, that's a very good question, because as we know, early glaucoma is in which is the kind of situation in which the OCT works better. Mm-hmm. There's a lot of discussion through this. There's even discussion in the number of fields we should do. But in my experience and seeing all the studies that have been published, I do my fields and my OCT at the same time. So if I have an early glaucoma and the pressure is controlled in a way that I feel comfortable with, then maybe I can do this every 6 or 8 months. But then I would do the two things, field and OCT with, fibers and macula. If I have a question or if pressure I don't feel comfortable with, or maybe if I see a hemorrhage in the examination, maybe I'll do it more frequent. But the current idea that we have is the frequency of testing you do, use all the things you have.
Yeah. And so for us old timers, there's a couple of questions in here. Again, I'm saying for us old timers being me, not you. Where do you put optic nerve photos in the use of monitoring your glaucoma patients?
Yeah, and that's I didn't put due to the time I didn't talk about photos, and because it's not an innovation, but I use photos a lot. Especially I like photos the very first time I see the patient. So in a first visit, my recommendation is to do a photo, and then repeat it if you see a change, or if so, at least every 2 or 3 years to have one, because sometimes there are things that are very evident in pictures. For example, hemorrhages. There are studies in the OATS that even glaucoma specialists miss hemorrhages a lot of time. So you don't see a hemorrhage in an OCT, and we know that means something's happening. So I will encourage people to do pictures, not every visit, but at least the very first visit, to have as a comparator, as a baseline.
Yeah, and I'm sure you're familiar with the EGS and AGIS criteria for progression. Would you follow their standards, or do you follow the progression standards for GPA that are built into the devices?
Well, as I said, because I'm an OCT person and I like research, I use all this information together. Both EGS and AGS have recommendations. It's not easy to know what is structural progression. So today, progression in general, glaucomatous progression, is based mainly on fields. But we know there are things that we can, that we are missing if we use fields only. So I use also OCT a lot in those situations in which I have said that I think structure helps us. But of course, we cannot only rely on how significant the slope is, especially in OCT, because this is not corrected by age. And if we use only this is significant, then we will have too much progression. We have to understand the numbers, to look at, I didn't talk about this either, but use reliable tests with good quality. Sometimes we have a low signal strength, like a low quality image, we will get a number 2. We will get colors too. The, red disease we've been talking sometimes, or the green disease, we get these numbers. But we are ophthalmologists, and we need to, explore a little bit more. And this can act as a confounder in our tests. So it's important to understand what we are looking, but more and more studies are telling us that if we have a progression that exceeds this micron that I was saying, this could be clinically significant. So if in this case, I think we should, treat.
And so one I think we've already answered, but just in case somebody didn't catch it earlier, is can you do GPA in a 24-2C?
Yes, you can do GPA, and you can do GPA even with other strategies that have been done. So you can use your previous data, and that's very important to not lose follow-up of your patient, because in glaucoma progression is so important. So yes, you can use it.
So here we go. In a young person with a high IOP and high corneal thickness, which explains the IOP, do you adjust for that with your OCT and visual field data that you're looking at? So in a young person with high IOP and high corneal thickness, which explains the IOP, high IOP after adjustments, do you investigate further with OCT and visual field?
Yeah, now I got it. Yeah. I think that it depends on which kind of health system you are. Of course, I think that at least one person that has a high pressure, it should be at least done one time, all testing. Maybe not forever, but at least one time, even with high thickness. Because of course it influences, and we know by oaths that corneal thickness is very important, but I have cases of patients with glaucoma and a thick cornea. So at least we need to explore. We don't know if this patient has risk factors, family history, we don't know. But at least I think it deserves one time to be seen. And if everything turns normal, maybe it's fine. I'm not very much of a fan of correcting by corneal thickness. In terms of I subtract 7 to my IUP because of the cornea, because there are other factors, not only thickness, but elasticity or biomechanics that play a role that we cannot use in these formulas. So I'm more of a, use it as a general idea of risk. So if it's thin, then it's higher risk if it's thick. But I don't correct because of these, because there are other factors that play a role that we cannot measure. But I think that every time you have one factor, you need to study to see if you have more. If everything turns normal, then maybe you cannot repeat, you don't need to repeat.
Yeah. Well, we have got lots of questions on here that are just saying what a wonderful presentation it is. So we'll be here all day if I read all of those. There is one that I do want to address. It's a lot of people asking about sanitation of the OCT, of the HFA. I can send out the clinical guidelines that have been posted on the EGS and on the AGS websites from ZEISS. We'll send that out to everyone who registered for this meeting. I think it'll be helpful. I do appreciate your time, and I think we all learned a great deal from your presentation. Thank you so much for what you're doing, and stay safe out there.
Yeah, you too, and thank you very much for inviting me, and stay all safe.
And thank you, audience, for joining us as well. Bye-bye.
Bye.